Good morning, everyone. Welcome to our AASLD session on practical treatment approaches to alcohol-associated liver disease. I'm Brittany Bromfield. I'm a second-year GI fellow at the Brigham and Women's Hospital, and I am so honored to be co-moderating this session with Dr. Sutat Liangpuntsakul from Indiana University. As you all know, alcohol-associated liver disease is a major public health challenge and remains one of the leading causes of liver-related morbidity and mortality worldwide. As clinicians and researchers, we are being increasingly confronted with this growing burden, from acute severe presentations such as alcohol-associated hepatitis to that chronic, often underexplored area of metabolic dysfunction in ALD. Today's session brings together leading experts who will provide us with practical and evidence-based insights into how we can care for these patients across this complex disease continuum. We'll begin with Dr. Jean Im from Columbia, who will walk us through how we treat alcohol-associated hepatitis, from current therapeutic approaches to evolving approaches in this high-risk population. Then we'll turn it over to Dr. Lamia Hawk from Yale, who will speak on managing AUD in the context of ALD, which requires an integrated multidisciplinary approach to achieve long-term recovery in these patients. Then Dr. Chen from Hopkins will help us with assessing metabolic dysfunction in ALD, which is a crucial but often overlooked component in the evaluation and management of these patients. And finally, Dr. Sasha Deutsch-Link from UNC will help us with early detection and screening in ALD, which is a key intervention in preventing long-term irreversible damage in these patients. We are thrilled to have such an esteemed lineup today and look forward to an engaging discussion. We'll have time for a Q&A at the end, so please think of questions as we go along. And with that, I'll turn it over to Dr. Im, who will kick us off.
Thanks, Brittany, for the kind introduction, and good morning, everyone. Appreciate your dedication coming this early. Okay, so I'm going to start us off with how I treat severe alcohol-associated hepatitis. Here are my disclosures. So the outline's pretty simple. Talk about the diagnosis of severe AH, prognosis assessment in severe AH, treatment of severe AH, and future considerations, which is more just practical tips. And a lot of this talk is more practical in terms of my approach to patients that are not often in the textbooks. All right. So, what is alcohol-associated hepatitis? It's a severe clinical syndrome of jaundice, decompensated liver disease, and coagulopathy that may develop abruptly in patients with underlying alcohol-associated liver disease and active drinking. The typical phenotype in the United States, and yes, this is an overgeneralization, but let's just give a sense, 40 to 60-year-old male, white or Hispanic, related to probably some genetic predispositions to developing advanced ALD and AH. But with a caveat that the demographics are changing, all right? So that was sort of the classic phenotype, but now we're seeing much younger patients, 20-year-olds with severe ALK-HEP and very poor prognosis, women, persons of color, those who are obese, history of bariatric surgery. There was a session, an abstract that was presented yesterday on that. Now, if you look at the definition, it's actually kind of vague, right? Jaundice, decompensation, coagulopathy, they're not really clear criteria here, right? So, that vagueness was sort of codified in this NIAAA consensus meeting where investigators and experts put together basically a clinical diagnosis pathway or criteria, mostly for clinical trials, but we find it very useful for the clinic as well. So you start with the clinical diagnosis first. This is prolonged use of, at least, 3 to 5 drinks a day, sex-based. But oftentimes patients are drinking much more than that. There needs to be a recent onset of jaundice, usually in the prior 8 weeks. So this is not something that's been there for a while. This is sort of a sudden thing. And sudden coming along with that is often the presence of ascites, malaise, fever, tender hepatomegaly, and asterixis. But you can see that the percentages are quite low. And so patients don't always present with these things. Okay? The laboratory markers, the patients need to be jaundiced, so total bilirubin of greater than 3. Now, that used to be more like 5, but they lowered it down to allow for clinical trials to be performed in patients with moderate alcohol-associated hepatitis. But sometimes that can get a little confusing because 3 is around when you first start seeing jaundice, right? But the classic, in order to have ALKEP, you must have jaundice. All right, so I want to emphasize that point. AST and ALT ratios are very classic from medical school in terms of elevations, but the values for both AST and ALT should not be over 400. When they're over 400, you have to start thinking about confounding factors, right? So again, bilirubin usually much higher, and they need to have jaundice. Okay. Oh, this is a reminder to tell you that in advanced MASH cirrhosis, the AST-ALT ratio can also rise, where the AST can be predominant. And remember, that's the factor why the NAFLD fibrosis score or the FIB4 has that AST component that in cirrhosis it rises predictive of fibrosis. So in the absence of a very clear alcohol history and other factors, that can be suggestive of MASH cirrhosis too. So you got to be a little bit careful there. So some confounding factors, especially with the transaminases in 800, 1,000, you got to rule out ischemic hepatitis, cocaine use, hypertension, shock, metabolic liver disease. I think Wilson's alpha-1 is pretty easy, but you often see ferritins being ordered. Or IgG levels. These are things that are not very specific. They're more specific. They're related to inflammation, which there is a severe form of in severe ALKEP, and it's not. I've never seen actually a hereditary hemochromatosis as a result. With severe ALKEP. I'll keep looking, and that's not really how it behaves as well, right? As a fulminant type of presentation. Look for possible drug-induced liver injury. I usually set it at 30 days to 3 months. I ask specifically about recent antibiotics, right? Did you take a course of, Augmentin for 1 week for a sinusitis, for example? And, I would say maybe 1 out of 5 people say that they indeed have done that. Check your meds along the NIAAA or NIH liver tox website so you can be very precise about whether there may be offending agents, particularly with polypharmacy. Now, with uncertain alcohol use assessment, that used to be a major problem because we only had serum ethanol levels, for example, but now we have PEth. Yes, it takes 5 or 7 business days to come back, but it is something that can help verify the history that you've obtained in the hospital. And then the presence of atypical laboratory tests. We like to sometimes take a shotgun approach when we have a patient with jaundice and acute liver injury, particularly with ANAs, SMAs, AMAs, right? But I urge you to think about what the typical presentations are for PBC, PSC, right? These are usually not abrupt, sudden jaundice episodes. However, for AIH, autoimmune hepatitis, it can be, right? So that's probably the biggest one that you have to rule out. That being said, if your presentation is of a 59-year-old man with new onset AIH, the likelihoods are against you with that, right? Because that's not usually how the distribution is, right? Okay, let's move on to diagnosis. So when you've evaluated the clinical diagnosis, the confounding factors, then you have these sort of 3 categories: possible AH with potential confounders, probable AH without those confounders, you rule them out, and then definite AH when you have a liver biopsy that demonstrates alcohol steatohepatitis. It is recommended in the guidelines that if you have possible AH with significant confounders, then you should move on to a biopsy because of the clinical uncertainty. So this is a practical thing. My initial workup is I often admit patients to the hospital for severe ALKEP if they come somehow to the office. I do a rigorous infectious workup, chest x-ray, pan culture, that's ascites, blood, urine, and it's in the emergency room. You need to have a good relationship with your ER docs to make sure that gets done right away and done before empiric antibiotics are given. If they're unstable, then you just got to give it. However, if they're stable, meaning no SIRS or ACLF type of criteria, then I would hold off and observe. Typical viral hepatitis serologies, usually ultrasound to evaluate for biliary obstruction. That's probably a board's question because you really want to make it low cost and also avoid IV contrast. Avoid long-acting opioids or benzos. Monitor for alcohol withdrawal. These patients often are very uncomfortable. They don't have a very high pain tolerance. Their bellies are big, newly stretched with ascites or tender hepatomegaly. And you want to avoid aggressive diuresis, even if their creatinine is pretty normal. You want to be gentle with them because things can happen quickly and get out of control. All right, so let's move on from diagnosis now to prognosis, okay? So the prognosis of alcohol-associated hepatitis is probably familiar to you all. There are many different scores. The classic ones are the modified Madri's discriminant function at the top, MELD score. There's also age, bilirubin, INR, creatinine, or ABIC, Glasgow alcohol hepatitis score, and the Lille score, the Lille model. And this table sort of shows that there are many shared variables that all of you are probably very familiar with. These are all many components of familiar things in terms of scoring systems, all right? So, unlike other diseases where you have a diagnosis and you treat them, severity or prognosis of ALCHEP is really important. So prognosis dictates the treatment approach in ALCHEP. So the thresholds are MDF of 32 or a MELD of 20. If it's less than that, then they have moderate alcohol-associated hepatitis, and you can see that the mortality, while it's sizable and not something I'd want to have, but it's much lower, 3 to 7% at 3 months. And because of that, abstinence and supportive care are often sufficient. Whereas the cutoff of 32 and a MELD of, again, above those thresholds, patients are diagnosed with severe ALCHEP and look at their mortality, 20 to 50% at 3 months. You could argue that's even higher if you're a non-responder. It could be 70% at 3 months, right? That's a grim prognosis, aligned with worst kinds of cancers, right? In that case, again, abstinence, supportive care, and in this case, this is where the pathway to medical therapy, such as corticosteroids, you get started on. So this is a snippet from www.lillemodel.com, which is probably my favorite calculator. Yes, you can use MDCalc. That's one that pops up first on Google. But what I like about the Lille model, besides that it was devised by the experts who created it, is that once you input the data, you can then switch by clicking MELD score, Madri's, and they'll automatically calculate them without you having to put them in again. I just note that when you put in for the Lille model, you have to be careful about the units for albumin, right? Because we usually in the U.S. have it as grams per deciliter, and so that can be a little bit tricky. But I like this calculator. Okay? There's been some data that suggests that MELD outperforms the discriminant function. These are two papers from the STOP IT trial and a multinational trial headed by Romain Bataillé. And you can see that MELD had a greater area under the curve for predicting 28-day and also 90-day mortality, with the AUCs there. Statistically, it's important, but in reality, it's really 1 patient out of 10, right? So you're getting 7 patients right, or whatever, 7 and 3/4 patients versus 6 and a half patients right. So it's really you're going to identify 1 patient out of 10 in terms of prognosis versus the discriminant function. Okay, so still not perfect. There is a new practical model that I was involved with that incorporates age. We try to answer the question, if a patient has severe ALCHEP who needs a transplant but cannot get a transplant for psychosocial reasons or decline for transplant, roughly around the waitlist decision about 5 days from presentation, can we predict whether they'll survive long enough to then either recompensate or be able to be a transplant candidate in the future? And we found that when we added age, not surprisingly, younger age did better, right? That outperformed discriminant function and Lille score. And you can see sort of a kind of a simplified threshold of MELD greater than 35 or age greater than 45. There's quite a big difference in the survival curves. So something to consider. Age is also in other scores like the Glasgow hepatitis score. Oh, and if you're interested, there is an online calculator, because that's the cool thing to do nowadays, right? All right. Let's talk about treatment. I could take another hour and talk about corticosteroids and the data behind it, but I'll keep it real simple and say 50 years of research largely supports steroids to improve survival. I think the best study incorporates individual data from 12 placebo-controlled clinical trials, including STOPPA, and you can see at the very top box, prednisolone versus control, it just barely, the forest plot is actually significant, suggestive of use to improve short-term survival only. Corticosteroids are still recommended by all GI and liver societies. The newest one is from ACG, and they still recommend the use of corticosteroids for severe ALCAP. So the Lille score you're probably familiar with. It's a validated dynamic model that helps you make decisions about the duration and utility of continuing corticosteroids at 7 days. Okay, the classic is if your Lille score is less than 0.45, their bilirubins come down, they're a responder, keep going, right? And if it's above that, then they have a poor prognosis, they're non-responders, and you should stop because you're going to get them infected, right? But I just want to point out that there is actually data for partial response, and I don't think that this is talked about enough. So these are patients who their Lille score at day 7, it goes down, but it's more like 0.55, right, rather than 0.45. Well, their survival in 28 days, if you continue the steroids, is still 80%, 79%. I'll take that over 53% for a non-response, right? So don't be too quick to stop the steroids, even if they have a sort of incomplete response, because I do think that outside of this, you have nothing, right? So you might as well try to, use it to your fullest advantage. Okay. Now, what about changes in Lille? Well, there's a nice study, again, multinational study led by Spanish investigators looking at over 200 severe ALCAP patients, the majority of whom received corticosteroids. And they said, well, what if we calculate the day 4 Lille score the Lille score at day 4 a little bit early, so we can make decisions whether they can continue steroids, get out of the hospital, and whatnot. And they found that there was a strong agreement between day 4 versus day 7, and that impacts the length of stay, and I think that's important. And there was still a similar predictive value for mortality between those two days, day 4 and day 7 Lille for short-term mortality, and you can make decisions a little bit earlier. I don't always use day 4, but I do think it's useful to say if your bilirubin after 4 days stays exactly the same or increases, the patient's not responding. You might as well just cut bait at that point, right? If they're coming down, then maybe you want to wait to day 7. And why are we so sort of nervous about corticosteroids? Well, I think it has to do with infections, right? So some precautions are that almost about a quarter of patients or a fifth of patients walk in the hospital infected. Okay, so that pan culture slide recommendation is important. Another quarter of patients get infected during treatment, and from the STOPPA trial, a small percentage of patients get infected after treatment. That's beyond the 28 days. Okay, and the most common infections. This is from the Lille group in France. Actually, is SBP or bacteremia. Hence the comments about needing a diagnostic paracentesis in the emergency room, right? Now, that being said, for those non-severe infections, you could actually get that under control, right? Even with GI bleeding, right? Get it under control, and maybe 5 to 7 days later, you can give them corticosteroids if they're otherwise not infected. And so this is a statement from a nice New England Journal review from Ramon and JP. Controlled infections are not contraindications to the use of glucocorticoids, all right? So yeah, you may feel a little bit bold, but otherwise, what are you doing for the liver to actually give a liver-specific treatment to reduce inflammation? Second precaution is AKI. AKI is quite common. 1/3 of patients with severe ALCAP, mostly it's hepatorenal syndrome, is particularly important because it's associated with a 9-fold increase in 90-day mortality. And that speaks to the fact that I spoke to you before, that the MELD score seems to predict outcomes a little bit better than the MADRS discriminant function because you have that creatinine AKI component to that. The creatinine is not part of the discriminant function. I would say that AKI is a contraindication for steroids, mostly because AKI was excluded in the prospective case series and clinical trials like STOPPA. It permitted a creatinine of up to 2.5, but if memory serves me correct, The median creatinine in that trial was 0.9. Okay, so they're not really sort of multi-organ AKI patients. If it occurs, you should really think about a transplant evaluation, referral, and/or a palliative care evaluation. Another precaution is ACLF. Okay, I'll go on a limb and say that most severe ALCEP is ACLF. Okay, at least the bilirubin liver component. This is a study from France that looked at biopsy-proven severe ALCEP. They found that almost half of patients with severe ALCEP had ACLF at admission. Okay, that includes just grade 1. And then another 18% developed it during admission, and most of that was related to a new infection while hospitalized. So severe ALCEP with ACLF grade 2 and 3 predicted increased mortality versus ACLF 0 to 1. So it's really 2 or 3, that's the cutoff. And investigators in France and in the STOP-IT trial in a post-hoc analysis demonstrated that if you have ACLF, even ACLF grade 1, you have a lesser response to corticosteroids. And I guess that's not too much of a surprise in the sense that you have too many organ failures and the liver is too far gone at that point. We use antibiotic prophylaxis in cirrhosis with GI bleeding, right? Here's a meta-analysis demonstrating that there's a strong concordance with infections that precipitate the bleed, and so you treat both, right? Unlike a non-portal hypertension-related bleeding that actually improves survival. So why don't we do that the same if infections are so problematic in severe ALCEP? Well, this trial was done. The anti-BioCore trial from the Lille group, looking at augmentin plus prednisolone versus prednisolone alone for 30 days. Unfortunately, there was no survival difference seen at 2 months, even 1 or 3 months. You can eyeball it, didn't really help. Not surprisingly, there were lower rates of infection, but I guess the point is it's not so much the infection, it's the ability for you to get the liver to regenerate and improve. An often overlooked study is the N-L-cysteine study for alcohol-associated hepatitis. Okay, in combination with prednisolone, it was a negative trial because the endpoint was 3 months, but it preceded the STOP-IT trial, which demonstrated that really the appropriate endpoint for steroids is 1 month or 28 days. And at 1 month, actually, if they put that as the endpoint, it was statistically significant. So more data is needed. I think there's a trial in France looking at that. So, you admit the patient while the cultures are cooking. It's important to remember to provide supportive care. Okay, CWAP protocol for alcohol withdrawal, treat decompensation. Depending on the patient, try to provide enteral nutrition. I like to put NG tubes in my patients early on, not the stiff ones, but the Daboff or FlexiFlow ones, and not wait on that. Remember, the median time to liver biopsy in the clinical trials is 6 days, right? So you have some time to observe patients. And also, there's new data to suggest that if you have a patient, and you've seen this, where their bilirubin just gets better, you're not really doing anything for them. They've stopped drinking, you're giving supportive care, and they have this fast faller in bilirubin. So if their bilirubin declines more than 20% at day 7, or you can assess it earlier, then they have the same outcome as if they're a responder to steroids. So you don't need to give it to them. Okay. However, if their bilirubin is static or they rise, like we discussed before, then they're in trouble. Okay, and you should really think about steroids in them. Right. So there is this observation period that is useful. We shouldn't be giving medicines like this in the emergency room. Last couple slides to finish it up. There's been some interesting studies, mostly coming from J.P. Arab. So there is an old teaching that prednisolone is better, more bioavailable than prednisone. There's a nice Liver Fellow Network web page on this, led by Hannah Blaney. I suggest you read it. But with that, this retrospective international multi-center cohort study showed that basically whether you use prednisone, prednisolone, methylprednisone, they're all the same in terms of efficacy. Lastly, this paper just came out in the Red Journal called the STASH trial. The idea is, could we start a patient on the 40 milligrams of prednisone and then start tapering it right away by 10 milligrams every week? And will that still provide benefit but lowering infections? And the answer is yes. Lower infections, but no difference in terms of mortality. So it still worked even though you started at 40, 30, 20, 10, then off. Okay, My last slide, all right? So putting it all together, I hope to convince you that my approach is to diagnose AH with the NIAAA criteria, possible, probable, definite, prognose alcohol hepatitis, moderate or severe based on those cutoffs, observe for a little bit, gather some data, supportive care. If they have AKI or ACLF2 or 3, that's a stop sign, no steroids, and you think about liver transplant or palliative care. If they're a fast follower, also red light, and they should consider going home or rehab. If they're stable, then you move on to treat ALKEP. I like steroids plus IV NAC for about 4 days. You reprognose with the allele score based on response, and either you continue steroids with a taper with alcohol use disorder treatments, or they go to the transplant pathway. Thanks for listening.
I think for the sake of time, we're going to move on to the next talk. How to manage alcohol use disorder in the context of ALD by Lamia Haig from Yale University. Yeah, perfect. Thank you.
Okay. All right, good morning. Thank you so much to the organizers for setting up this panel. I think that it's really an important topic with a big public health impact. So we're going to talk about how to sort of shift gears and treat alcohol use disorder in patients with alcohol-associated liver disease. So I'll talk a little bit about the alcohol use disorder treatment gap, some approaches to providing this care and delivering this care, as well as sort of what we can do today in our clinics to be able to provide this care or start to do that for our patients. Alcohol use disorder has a relatively high prevalence. So this is data from the National Surveys on Drug Use and Health through SAMHSA that shows that from the most recent study, there are over 28 million individuals who reported past year alcohol use disorder. So that's about 10%. And this exceeds kind of all drug use disorders combined. So definitely a staggering kind of public health presence. But that very few individuals receive treatment despite having these diagnoses. So you can see that between 5 to 10% in general, depending on the study, but overall, usually less than 10%. There have been multiple observational studies that have shown that treatment of alcohol use disorder has positive liver-related outcomes that are associated with it. This was a study using data from MGH that showed that among people with alcohol use disorder, receiving treatment for alcohol use disorder was associated with less development of alcohol-associated liver disease, and that when people who already had alcohol-associated liver disease, or specifically in this study, alcohol-associated cirrhosis, received alcohol use disorder treatment, that they were less likely to develop hepatic decompensation. In addition, studies have shown that receiving this care in a timely fashion is very important, and this is a study that followed individuals similar to the population that Dr. Im was describing, people who had severe alcohol-associated hepatitis, and what their outcomes were depending on whether they received early addiction treatment. Individuals who received what they referred to as alcohol rehabilitation, which was sort of any type of addiction treatment in their definition within 30 days, had better survival than those who didn't. So despite this growing evidence, we still have a substantial alcohol treatment gap, like is the case with many substance use disorders. And this is just data from a few different studies that show that in general, even in the highest risk groups, in individuals who have significant medical complications of alcohol use disorder, in a VA study, 14% received any alcohol use disorder treatment, of which only less than 2% was medication. Despite other populations that are more recent being studied that have current drinking at hazardous levels, still about 10% receive any kind of treatment. So definitely a long way to go to better deliver this care. Multiple barriers have been described, patient, clinician, and system level barriers, ranging from patients having difficulty accessing care due to transportation or insurance issues and things like that. Stigma is a huge barrier that's been described. From the clinician side, unfamiliarity with medications and other types of alcohol use disorder treatments, and on the systems level, various factors that make it difficult to incorporate this treatment into general medical settings. Integrated care models have been described and various types of delivery, including inpatient settings as well as outpatient settings. And this is just a figure showing that it can be done at different levels with different degrees of intensity by different types of providers, and that it does take a multidisciplinary approach to be able to deliver the most comprehensive care. But despite that, I think that there are definitely components of treatment for alcohol use disorder that were really designed to be delivered in general medical settings that can be done in our clinics, even as we sort of practice in GI and hepatology now. And so I'll kind of shift gears and go through just some basics on how to provide this care, hoping that this can provide a foundation to be able to consider this in our practices. So I'll start with the definition of addiction. This is from the American Society of Addiction Medicine. Addiction is a treatable chronic medical disease involving complex interactions between brain circuitry, genetics, the environment, life experiences, and that what really sort of defines addiction is engagement with a substance that is leading to harmful consequences, of which perhaps there is a loss of control. And so there are multiple factors that are involved. There are predictors, but they're not perfect as far as sort of who will develop addiction versus not when they're exposed to a substance. And ultimately, I think the take home is that this is a chronic condition, just like any other chronic condition that we treat, and have treatments that work as well or sometimes better than other chronic conditions that we treat. So how do we diagnose addiction or alcohol use disorder, which is one form of it? We use the Diagnostic and Statistical Manual for Mental Health Disorders, the DSM-5. This is the criteria here. I won't go through all of them, but they fall into the categories of physiological manifestations, loss of control, and negative consequences. And if a patient has 2 or 3, then they are falling into sort of the mild substance use disorder or alcohol use disorder category. Moderate is 4 to 5, and severe is 6 or more. This is just for your reference. The alcohol symptom checklist has been used widely in research as well as in clinical settings. It's a way to be able to ask these questions in clinical care. So what does it mean for recovery? We talk a lot about abstinence, which is, of course, the medically most safe outcome for patients with the least amount of risk. However, there is benefit to other non-abstinent outcomes that have been shown in research. And from sort of the National Institutes of Health, there are 2 different non-abstinent outcomes that are thought to be under the umbrella of recovery. One is remission from DSM-5 alcohol use disorder, which means that a person no longer is fitting that 11 criteria, and so basically have less than 2 criteria. So you can still have theoretically some degree of alcohol consumption without fitting the criteria, though of course it depends on the individual whether that would be advisable or not. And then cessation of heavy drinking. And so when somebody is in recovery, we can also stratify that by initial, early, sustained, or stable, and these are sort of the cutoffs here. And I think I also wanted to just go over the spectrum of alcohol consumption. So not all drinking is the same. There are many different categories and classifications of drinking, and they're listed here. I won't go through everything, but there is sort of lower risk drinking. We now no longer refer to any drinking as like safe drinking, because as I think has sort of come to the public consciousness more with the Surgeon General report, there's other harmful effects due to alcohol beyond, the liver, of course, and what we see in our clinics. And so we sort of refer to it as lower risk drinking based on kind of the standard drink definitions and comorbidities. And then there's a variety of other types of drinking here. And of course, at the bottom is alcohol use disorder. I wanted to just briefly highlight the importance of thinking about harm reduction, so the non-abstinent outcomes, as well as kind of what recovery and the process means for the individual within the context of their lives and the consequences and their quality of life. I think that ways in which we can broadly approach having these discussions are by using motivational interviewing, by in general approaching things in a very respectful and sensitive way, by using shared decision making, and of course advocating for our patients. I think many of our patients have been marginalized stigmatized by the medical system, have had very negative interactions in the medical system. So being a space that is inviting and welcoming and sort of affirming is really important. And I think along those lines is using patient-centered, medically accurate language. And so these are some examples of that. I think historically there have been both in addiction treatment as well as overall medical settings, use of the terms that are kind of on the left side there, alcoholic and sort of, clean, sober, a clean urine or a dirty urine, that kind of thing. We've really kind of moved away from all of that. And I think for our purposes, using terms like alcohol-associated liver disease, sometimes people say alcohol-related liver disease, as opposed to alcoholic liver disease, person with alcohol use disorder. We hear a lot of recidivism, when we think about sort of return to drinking, really we should sort of use terms like return to drinking. And I think that, again, just sets the tone for how we think about and talk about our patients. So there are different levels of care for alcohol use disorder, and this is just, again, from the American Society of Addiction Medicine, from sort of very intensive inpatient to residential kind of outpatient programs to outpatient clinical visits. And I wanted to briefly highlight that, of course, we always think about counseling and IOP and kind of the 12 steps and things like that, which are all very important, but are just one component of addiction treatment. And this is a review that was published that kind of highlights all of this and how the evidence that we have in alcohol-associated liver disease. So this is just kind of for your reference. I'm going to talk a little bit about the medications. I'll kind of fly through them because we're a little limited on time, but this is again a table from that same review that summarizes the medications, the doses, some of the considerations in liver disease. And so briefly, naltrexone is one of the ones with the most robust evidence overall in alcohol use disorder. These are kind of the doses, side effects, and contraindications. The main issue is you need to make sure the patient isn't taking opioids. Sometimes that requires a very detailed history and maybe a urine toxicology, but overall, most individuals are able to tell us. And we'll talk a little bit about the safety in a later slide. Acamprosate is one we commonly use in our patients just because there's no real association at all with any kind of liver injury. The main consideration is renal impairment. Disulfiram is one that I think many of us are familiar with as far as one that has caused fulminant liver injury, though in rare cases. This is one that in general has not been used too commonly, except in very select circumstances, such as opioid treatment programs, directly observed sort of situations, patients who are highly motivated or for whom the other options haven't been effective, but is one that we would avoid in any sort of clinically significant liver disease. Gabapentin is commonly used, is off-label, but has good data and is often also used for treating the comorbidities or other symptoms that one might have in alcohol use disorder, such as sleep issues, neuropathy, and things like that. Sorry, went backwards. Okay. Topiramate is one that also has pretty robust evidence, actually, overall. I think some of the considerations in our population are the cognitive effects that can occur. And so this would be kind of a starting low and going slow medication in our population. And finally, baclofen is a medication that has had some small trials in patients with cirrhosis, was, I think, favored more in patients with liver disease historically. There have been other studies that have not had as favorable results, and so in general, in addiction medicine circles really is not used as a first or second line medication, but is still an option with some evidence. So I wanted to highlight that medications for alcohol use disorder overall are felt to have a moderate effect size, but that when you look at the numbers needed to treat, there have been several meta-analyses, one more recently showing that the number needed to treat to prevent any return to drinking for naltrexone is 18, acamprosate is 11. That's pretty good compared to many of the medications that we prescribe for common indications like statins, antidepressants, et cetera. So I'll go very quickly through the safety of medications for alcohol use disorder. Historically, there's been a lot of attention on naltrexone because there was a black box warning that was lifted over a decade ago now, but I think historically it's just kind of stuck on to naltrexone like a scarlet letter. And so there were studies using higher doses of naltrexone in different populations that showed that there was an association between exposure and higher liver enzymes. That now is felt to be probably due to other confounders in patients and due to the dosing in certain trials that used that from which that conclusion was made. There have been multiple observational studies recently that have shown that there is really not a significant increase in liver enzymes, actually, even in patients with advanced liver disease that we see who are taking naltrexone. And in some of the studies using large data sets like the VA, when they looked at the cases, the few cases in whom liver enzymes were elevated, they felt that it was not actually due to the naltrexone, but other issues that the patients were having, drinking or other types of exposures. So that's sort of what we know about naltrexone now from observational data, which is very encouraging. I'll talk a little bit about disulfiram. So I think, in the GI liver world, we're very familiar with the severe fulminant liver injury, which should definitely be something that we think about and rule out significant liver disease in our patients before prescribing. We don't have a ton of data describing this aside from kind of the case series and liver tox, but there was one study that was recently published using the Dillon data. They looked through all of the high confidence DILI cases, found that 13 were attributed to medications for alcohol use disorder, of which mostly were disulfiram, and among those that were significant with jaundice, which is sort of when you start to really worry with disulfiram, there were 3 fatal or non-fatal cases, and most of those patients had underlying liver disease. So overall, it's not super common, but definitely something that we want to protect our patients from. This is a figure from work that I did with Dr. Im to try to kind of consolidate how do we think about prescribing these medications in our patients. This is from the PCSS MAUD, which I'll sort of describe what that is in a little bit briefly. But basically if you have a patient in front of us, of course we take a detailed history, we want to know about their other substance use and things like that. And when we're thinking about alcohol, we want to think about whether they've had withdrawal or are having currently withdrawal or recently had withdrawal symptoms in their history. If that's the case, we want to manage that. But then we also want to stratify the severity of their alcohol use disorder. So is it mild, moderate, or severe? Ultimately, when it comes to medications, it can be offered for really any of these categories, but some of the guidances say, moderate or severe is when you really want to emphasize the medications more. We also want to, of course, include options for behavioral treatment, counseling, peer supports, mutual aid groups. And so coming down to the bottom, the way that we've kind of conceptualized it is thinking about patients who might have none or early alcohol-associated liver disease, advanced, or the more severe category, severe acute alcohol-associated hepatitis or decompensated cirrhosis. So ultimately, many of the medications are possible from a liver perspective in many of these patients with caveats. Disulfiram, really, you can consider in early alcohol-associated liver disease if you're truly certain that they don't have advanced fibrosis. It's not a hard contraindication, I think, based on sort of the FDA in kind of people who might have advanced fibrosis, but I think that given the risk and the fact that other medications have better evidence, it's best to avoid. So those are kind of the options here. And then when somebody does have advanced fibrosis or more severe forms of alcohol-associated liver disease, you want to think about what their other comorbidities are. Do they have renal dysfunction? Do they have issues with hepatic encephalopathy? Are there other reasons why they can't take any of these medications? And of course, other contraindications too, and then make a decision based on that. So this kind of summarizes all of that in a different way. I think for sake of time, I'll just say that patients often have preconceived notions about these medications, may have seen, peers or family or others on medications, may be most familiar with disulfiram and be worried about being sick if they're on the other medications. So really kind of understanding a patient's understanding of medications is important. Tapping into what their preferences might be, that really drives kind of which form of medication and the pill burden and things like that, what would be most acceptable to them. And then thinking through kind of the risks and benefits, including for some of the ones where, naltrexone, there's still maybe in severe cases of liver disease, we would want to think about the potential risk, the hepatic risk, or some of the other options, what the risk and benefit are of continued alcohol consumption versus exposure to the medication. And then these are kind of some of the things that we would monitor: how much are the patients drinking, quantity, frequency, cravings, symptoms or consequences related to drinking, biomarkers to see what their response is to the medication. This is just, there's more and more resources that are becoming available. So this is for your reference, but basically, the AASLD has some free resources that summarize this content as well as information on other addictions. The Provider Clinical Support System, Medications for Alcohol Use Disorder, is a very current resource that's still sort of being developed and added to, for which some of us have collaborated on providing liver-specific content, and it's free and available, sponsored by SAMHSA. There are several podcasts. There's the Liver Fellow Network, which has written wonderful articles on this, and of course the NIH. So with that, I will end. Thanks so much.
Thank you so much, Dr. Hawk, for that incredible discussion. Treating AUD and ALD is so critical to improving outcomes in these patients, so thank you so much. And with that, I'll turn it over to Dr. Chen on how we assess metabolic dysfunction in patients with ALD. Thank you.
All right, thank you for being here this morning, and thank you to the organizers for the invitation. I was tasked to talk about assessment of metabolic dysfunction in patients with ALD, and these are my disclosures. So today, for the next 20 minutes, we'll be talking about the cardiometabolic definitions for metabolic syndrome and steatotic liver disease. Talk about how alcohol can impact the cardiometabolic factors, and then we will examine it in reverse, how these factors can then impact ALD and MET-ALD. And hopefully, we'll try to do this in a story form with some data sprinkled in between. Here we have Joe at his initial GI clinic appointment. He's looking a bit worried. He says that my doctor said my liver tests are high and I need to see a liver doctor. And upon further probing, Joe says that, I don't really drink 3 to 4 beers a day on weekends, maybe 5 or 6 a day on weekdays, and maybe 5 or 6 a day on weekends and game days. So the doctor kind of did some quick mental math, and that's about 29 drinks a week. That seems like a fair bit of alcohol. This may be ALD, but the doctor correctly and thought about expanding the investigation, and much of which Dr. Im talked about during the first lecture. So the doctor looks down at the clinical data and sees that Joe is 41, and as I mentioned, 29 cans of beer a week, which roughly translates to about 400 grams of ethanol, and that's key. As far as routine labs that led to this visit from a couple weeks ago, you see normal CBC, the liver enzymes, the AST and ALT and bilirubin are a bit elevated in that 2-to-1 fashion. And as far as routine labs, there was a fasting lipid panel, and as you can see, the triglycerides were elevated, and the rest were okay. A1C was also in a normal range. So additional workup that's done at the GI clinic visit, includes some basic vitals and some basic checks. Height, Joe's height is 5'9", weight is 149 pounds, and that really calculates a body mass index of 22 kilograms per meter squared. The blood pressure is a bit elevated, it's 152/96, and then abdominal ultrasound does confirm hepatic steatosis with some hepatomegaly. And for the sake of the topic of today's topic, we'll just say that all other liver etiology screening was negative. So by my count, there is now hepatic steatosis, and there are 2 cardiometabolic risk factors in the hypertriglyceridemia and the hypertension. So where that puts Joe then, this is a slide that many of you have seen many times now, coming from the Multi-Society Disease Nomenclature group from 2 years ago, and where Joe would fit, once again, about 400 grams of ethanol a week and 2 cardiometabolic factors. He would be in the MET-ALD category. But more broadly, this is just an illustration. More broadly, what I hope to achieve in the next 15 minutes or so is to talk about how our understanding of MET-ALD since the publication of in 2023 really has come from the perspective, the vantage point almost as an extension of MASLD. And in fact, you can see it in the name. It's MASLD and increased alcohol intake. And what I'm hoping to kind of present is an emerging perspective, looking at ALD more from the perspective of ALD. And perhaps, perhaps there's a category that would be ALD with some cardiometabolic risk factors. But to do that, I think we have to start from kind of the beginning, talking about what are these cardiometabolic risk factors. There are 5. There's weight, glucose, hypertension, hypertriglyceridemia, and low HDL. And on the left here are the criteria that's used by the National Cholesterol Education Program 2 decades ago for defining metabolic syndrome. And on the right is the criteria used by the multidisciplinary nomenclature group. And you can see that the implementation of each individual cardiometabolic factor is actually really similar. A little bit of difference in weight, just by tweaking the category over the years, but really it's very similar. And the single biggest difference is that to achieve the internationally recognized criteria for metabolic syndrome, somebody needs 3 of these 5 risk factors. And for MASLD or MET-ALD, you need 1 of the 5. Now, this, by requiring just 1 of the 5 risk factors, I think that definition really increased the inclusivity of who can be diagnosed with either MASLD or MET-ALD, but maybe also accidentally, inadvertently introduced some noise into the definition and de-emphasized the potential impact of alcohol use on cardiometabolic risk factors. And what are these potential impacts? Just try to go through literature. This is my own cartoon. It's super simplified, but hopefully even through this super simplified cartoon, I'm able to convey that it's complicated. But in summary of this slide, really, a lot of excess alcohol use can adversely impact at least 4 of the 5 cardiometabolic risk factors: hypertension, hypertriglyceridemia, some increased blood glucose, increased weight, and the only one that it doesn't quite get there is that excess alcohol use can also tend to increase HDL. So that one doesn't quite contribute towards the cardiometabolic factors. So alcohol has a lot of effects on these risk factors. And as it turns out, these risk factors are really common overall in steatotic liver disease. So this is data from Denmark, single center from Denmark, and it really drives home a couple of points. First, it shows us that these risk factors are common. The median, 50% of people have 3 or more risk factors. And the distribution of the number of risk factors is actually pretty similar between MASLD and MET-ALD and ALD. Again, slight differences, but pretty similar. Another point to drive home here is that let me hope I have a pointer, but this bar here that looks blank, it's actually the pure ALD group. And you can see that that's only 5 out of this entire cohort. It was less than 2%. So it's pretty uncommon to have no cardiometabolic risk factors at all. And finally, the last point here is that the specific risk factors, slight differences, as I mentioned, because of alcohol's effects. MET-ALD and ALD tends to have a bit more hypertension, a bit more hypertriglyceridemia, but overall the distribution is fairly similar. But that 50% with 3 or more risk factors is key because, again, that defines metabolic syndrome. We've known for some time now that there is a supra-additive interaction between binge alcohol use and having metabolic syndrome, such that someone who has both has more risk for developing adverse liver events than the addition of metabolic syndrome alone or binge drinking alone. And that's that scary looking black bar right up here. And once again, that's 50%. That's half of the people that has steatotic liver disease that have MET-ALD and that has ALD. So that's why it is important, I hope, driving home the point that it is important to screen for metabolic factors no matter where someone is starting with in terms of their alcohol intake that they report in clinic. So now back back to Joe, asks, okay, I have liver disease. Does the label, does ALD, MALD, does the label really matter? And unfortunately, kind of does. The specific labeling here, this is data again from Denmark, the specific labeling here unfortunately does seem to inform the adverse outcomes in terms of liver decompensation and mortality. And the risk is alcohol is top, followed by ALD, followed by mast cell. And the number of cardiometabolic risk factors also matters. It's data from Spain, that shows us that here on the right side, among patients with ALD, increasing numbers of cardiometabolic risks does seem to increase the risk, incrementally increase the risk of advanced fibrosis. And the threshold in this Spanish population seems to be after or between 3 to 4 cardiometabolic risks. Now, Joe asks, well, okay, we now talk about this, nomenclature. What can I actually do to improve my liver? So let's see. I think it's tempting. We have increased alcohol use. We heard about how to treat AUD in the last lecture, but it's tempting to think about, we have a lot of medicines available for the various cardiometabolic risks. You can treat the hyperglycemia, you can treat the hypertension with pills. But I would like to offer, perhaps, it's important for us to think about this from certainly what is most beneficial for the patient early on, and what we can achieve from the alcohol vantage point. First of all cardiometabolic factors are not equal. And this is data from NHANES that gives us three points that I want to highlight. First of all, it does show us there is a threshold effect. It's a little bit lower than the Spanish data. The threshold effect here is between 2 to 3 cardiometabolic risk factors in terms of the increased risk for developing liver fibrosis. But the second point is that when you look at the group that uses alcohol more heavily, when you look at that group as a whole, having 0 or 1 or 2 cardiometabolic risk factor doesn't really increase one's risk for increasing liver fibrosis that much. You're not really getting that much bang for the buck if you focus only on reducing cardiometabolic risks in that particular subset. That's about 50% of the population. And I would offer that you probably will get farther if we focus on the driver here, which most likely is the increased excessive alcohol use. And finally, as I mentioned, all factors are not equal. Hypertension and diabetes outweigh the other 3 risk factors in terms of increasing the risk for liver fibrosis. So it begs the question, if we were to reduce alcohol use, can we improve these two cardiometabolic risk factors? Do we have data for that? Unfortunately, we do have data for hypertension at least. Busy slide, systematic review with meta-analyses of 36 trials, almost 3,000 participants. And when you blow it up, it turns out that there is a dose effect in terms of reducing alcohol use, improving hypertension. So if you start at a highest alcohol use category, you were to successfully reduce alcohol use, you have more blood pressure benefits. It's important to note that these 36 trials did not require everyone to completely stop alcohol use. So even just partial reduction already has some improvement. And if you were to kind of dig into specific trials, you do see that there is even more blood pressure reduction if they had successfully achieved full abstinence. Now, unfortunately, I'm not going to show you any data on the hyperglycemia side because data for hyperglycemia in terms of alcohol use, alcohol reduction is really mixed. So there's not a great signal there. It's much better. The data is much better for hypertension. But going back to NHANES data again, the specific type of alcohol use, not just the quantity, but specific types may also have some implications. Beer drinking tends to be associated with poor diet, as defined here by Healthy Eating Index. So basically, more vary from what the USDA recommends, more diverge from what the USDA recommends, and also associated with decreased physical activity. Definitely not implying that there's a causal relationship between beer drinking and the dietary and the lower physical activity. But I think what this is showing us is that there's an overarching social and behavioral construct that perhaps can serve as a good lever for change, a good point for counseling in the clinic, so that you're not just focusing on the alcohol use or the diet. You're hopefully able to help counsel across the board for healthier habits. All right, so finally, Joe now returns for a visit 3 months later. Your in-clinic counseling was successful. He reports sustained absence from alcohol confirmed by phosphatidylethanol. And at this point, I would recommend that we reassess cardiometabolic risk factors, acknowledging that just like alcohol use, metabolic risk factors are also dynamic. And there's a potential role here to revise management plan if indicated. Because in the beginning, I tried to de-emphasize using medications if there's not a great reason to do so. But now, if there is true abstinence and if the blood pressure remains super elevated, you can see how there could be a role for now adding additional treatments, additional medication treatments to reduce further the cardiometabolic risk factors. So that brings us to a few take-home points here. I would like to invite everyone to make alcohol and cardiometabolic assessment in your clinical routine for steatotic liver disease in general. But to kind of recognize there's a reason why we're doing that. It's because the correct classification helps us manage and helps prognosticate. ALD is more than ALD, is more than MASL in terms of bad liver outcomes. To take caution, to be careful when we're applying only one or even two cardiometabolic risk factors to diagnose ALD and MASL. Because even at lower amounts of alcohol, it is conceivable that it just increases the blood pressure just enough to meet that MASL category, and alcohol remains the driver behind all that. So be careful when there are only a couple of cardiometabolic risk factors, and to recognize that excessive alcohol use can contribute to that. And the initial the biggest value for biggest return, I guess, for your intervention may actually be on the alcohol side and not necessarily starting, with the cardiometabolic, side of things. And finally, to recognize that these are all very dynamic, that we should reassess alcohol use and the cardiometabolic factors both regularly and also after relevant clinical changes, such as if someone reports, that they've been absent now for an extended period of time. Thank you.
Thank you so much, Victor. We're going to move on to the last talk of this session. I think the most important thing is how can we screen these patients early. And Sasha Lin going to talk about early detection and screening of ALD.
All right. Hello, everyone. Thank you to DDW and the session organizers for inviting me to speak. Today, I'm going to be talking about early detection and screening for alcohol-associated liver disease. I have no relevant financial relationships to disclose. So this is my outline for my talk today. I'm first going to talk about who is at risk of ALD, who do we need to be thinking about screening. I'm going to talk about screening for unhealthy alcohol use and alcohol use disorder. I'm going to talk about the initial screening we do for ALD, and then end with a discussion of fibrosis assessment in ALD. So first, who is at risk of developing ALD in the first place? So this diagram demonstrates the spectrum of ALD, starting with a normal, healthy liver on top. And most people with heavy alcohol use, actually about like 90%, will have some steatosis on liver biopsy after 2 weeks of heavy alcohol consumption. However, this steatosis is reversible with alcohol cessation. A minority of these patients with heavy alcohol use do go on to develop advanced fibrosis or cirrhosis. But since steatosis and early fibrosis are reversible, how can we detect early disease so that we can intervene appropriately? So what's the prevalence of ALD in alcohol use disorder? This is a systematic review and meta-analysis in hepatology communications that examined this and looked at prevalence of ALD in the general population, primary care clinics, and among those with alcohol use disorder. Now, the studies and criteria for ALD in this meta-analysis were quite variable, but they estimated that about 51% of patients with alcohol use disorder had underlying ALD. However, I think this is probably an underestimate because we saw on this previous slide that up to 90% of patients with heavy alcohol use have some steatosis. So if we include that like early steatosis in the definition of ALD, it's probably higher. Now, what moderates the risk of alcohol-associated liver disease among those who have heavy alcohol consumption? We think that patterns of consumption may impact risk of developing ALD, like daily use, alcohol use while fasting, and binge consumption. We know that there are some genetic polymorphisms that increase risk of developing ALD in the setting of heavy alcohol use. Tobacco use, overweight and obesity, and co-occurring liver disease can increase that risk as well. And we know that for the same level of alcohol use, women are at higher risk of developing ALD than men. However, alcohol use is overall, heavy alcohol use is higher amongst men, and so ALD is still more prevalent than men. But as Dr. M had said, that the demographics are changing. We're seeing higher rates of ALD in women in particular. We know there are some protective factors as well, maybe coffee consumption, which I always like to hear can be protective against developing liver disease and ALD and also MASLD. And then we know there are some genetics also that can reduce risk. So metabolic syndrome actually compounds the risk of developing advanced liver disease in the setting of alcohol use. So this is a study from looking at NHANES data. And on the left here, we see that people with heavy alcohol use and no metabolic syndrome have lower rates of advanced liver disease compared to people with heavy alcohol use and underlying metabolic syndrome. We also know that ALD is diagnosed and treated at later stages of disease. So this is a multi-center study that was published by Shah and colleagues, and what they found is that patients with ALD were treated at much more, were first like kind of diagnosed and treated at much later stages of disease. So this really highlights the need for earlier screening and detection as well as referral in this patient population. So why is it important to diagnose ALD early? This was a study by Rasmussen and colleagues. Then they examined liver-related events in patients with ALD across the spectrum of different fibrosis stages. And what we see here is that patients with F2 fibrosis, intervention in alcohol use might be really, really impactful in this group because they had the people with F2 fibrosis who had no alcohol use had similar outcomes over time with as the people with F0 and F1 fibrosis. However, patients with F2 fibrosis and heavy alcohol use had much higher rates of liver-related events. Patients who already had advanced fibrosis or cirrhosis had high rates of liver-related events over time regardless. So this really drives home the point that it's really important to diagnose ALD earlier before it becomes symptomatic. Because ALD is so prevalent in patients with unhealthy alcohol use, we need to start with actually screening for unhealthy alcohol use and identifying who needs further evaluation for ALD. So what is unhealthy alcohol use? It's an umbrella term that encompasses a couple of different types of patterns of alcohol use. There's heavy alcohol use, binge consumption, and alcohol use disorder. Heavy alcohol use refers to greater than 14 drinks per week or 4 in a day for men, and then greater than 7 drinks per week or more than 3 in a day for women or men over the age of 65. And then binge consumption refers to greater than or equal to 5 drinks over 2 hours in men or greater than or equal to 4 drinks over 2 hours in women or men over the age of 65. So who should we be screening for unhealthy alcohol use? Now, I would argue everybody should get a screening for this, but the guidelines actually do suggest that we screen in a wide range of settings. So the ASLD recommends that we screen for unhealthy alcohol use in primary care settings, GI and hepatology clinics, emergency departments, inpatient settings. And the United States Preventive Services Task Force recommends this in all primary settings. So how should we screen for unhealthy alcohol use? So the U.S. Preventive Services Task Force does recommend using a couple of different screening tools that are short, feasible, but have decent screening parameters. And the two they recommend are the single alcohol screening questionnaire and then the Audit C, which is a 3-item screening questionnaire that's been adapted from a longer 10-item audit. So the single alcohol screening questionnaire involves asking patients how many times in the past year have you had 5 or more for men or 4 or more for women drinks per day. And if it's at least once, that's a positive screen. Now we see here there's a decent sensitivity and specificity for an alcohol use disorder with this one question. However, it does perform very differently across age groups. So think about like college students, they may have lower specificity in this group. And then the Audit C involves asking 3 questions. How often did you have a drink containing alcohol in the past year? How many drinks containing alcohol did you have on a typical day when you were drinking in the past year? And 3, how often did you have 6 or more drinks on one occasion in the past year? And the Audit C is considered positive if it's greater than or equal to 4 in men or 3 in women. And it's more sensitive than specific. So kind of lower levels or moderate levels of alcohol use do initially screen positive, but that's just a screen. And then that, invokes further history taking and a more in-depth assessment of the alcohol use patterns. So once a screen comes back positive, we really should obtain a detailed alcohol history. And Dr. Hawk already went over the criteria for use disorders, but this is just a reminder. There are 11 criteria for alcohol use disorder according to the DSM-5. And you don't necessarily have to go through all of this for every single patient, but just kind of thinking about what are some features of alcohol use that are really concerning that might indicate a use disorder that needs further treatment. All right, so once a patient meets criteria for unhealthy alcohol use or alcohol use disorder, it's time to screen for ALD in that patient population. So who should we screen for ALD? When I showed the slide earlier demonstrating the spectrum of ALD, we saw that chronic heavy alcohol use does lead to hepatic steatosis in a majority of patients. So as such, it's recommended that we screen for ALD in all patients with chronic unhealthy alcohol use. However, we also saw that having underlying metabolic syndrome compounds the risk of developing liver disease with alcohol use, and so even moderate alcohol use in the presence of some masked risk factors would be another population to screen for liver disease in. And how should we screen for ALD? So everything starts with a history and physical. We're talking about early detection of ALD, and so the physical exam is really not going to give you much in terms of that because these are patients who have asymptomatic liver disease. The history really involves the detailed alcohol history that we discussed. Start off with some basic blood work, CMP, CBC, INR if you think it's indicated, and then evaluating for co-occurring liver disease like chronic viral hepatitis, alpha-1 antitrypsin deficiency, and hereditary hemochromatosis. And then in select patients, consider evaluation for autoimmune hepatitis, PBC, Wilson disease. We should get an abdominal ultrasound, and this can show early hepatic steatosis potentially. And then it can also even show some nodularity or splenomegaly that might indicate the presence of cirrhosis. And then finally, these patients should get a non-invasive assessment of fibrosis to stage their liver disease. And I'm going to go into exactly how we do that. So this leads into my discussion of fibrosis assessment in ALD. Fibrosis assessment in ALD mainly involves non-invasive testing, unless the underlying diagnosis is in question, and I'll show some of the data about why we really stick to non-invasive methods for the most part. So first, let's discuss serologic testing. Here are several serologic testing methods that we can evaluate for fibrosis and ALD. The two that are most commonly used, or that I see the most commonly used, are the FIB4, which looks at age, AST, ALT, and platelet count, and has designated cutoffs for low risk, intermediate risk, and high risk of advanced fibrosis. It may not perform quite as well, particularly with regards to the specificity in ALD, due to the unique impact of alcohol on AST and platelets. And then there's the Enhanced Liver Fibrosis Panel. This looks at 3 different markers of fibrosis, and we generally see a cutoff of 9.8 or 10.5 in the literature for detection of advanced fibrosis in these patients. There are various other serologic testing that we can do, consider, like the APRI, Fornes Index, Liver Risk Score, and Fibro Test, and I'll go over some of the data about why FIB4 and ELF tend to be used more commonly. I also want to talk about another modality that's very commonly used, vibration-controlled transient elastography. This involves using a machine that uses shear wave imaging to estimate liver stiffness. Liver stiffness measurements can be impacted by acute alcohol use, and so we can even see reductions in liver stiffness after even short periods of abstinence. And the generally accepted cutoffs for moderate fibrosis are around 8 to 10 kilopascals and 15 kilopascals for more advanced fibrosis. So how does the FIB4 perform in ALD? It may be more kind of elevated in this patient population because of its alcohol's unique impact on AST and platelets, which factor heavily into the FIB4 calculation. However, it still performs pretty well as a screening test with pretty good negative predictive value especially for advanced fibrosis. When compared to transient elastography, a FIB4 cutoff of 1.3 has poor positive predictive value, but pretty good negative predictive value. And then when we use a higher cutoff of 3.25, obviously the specificity improves and the positive predictive value improves pretty significantly, but we see our sensitivity decrease. This is one of the studies that is kind of the most comprehensive, looking at non-invasive assessment of fibrosis in ALD. It was published in Gastro in 2019. And what they found is in intention to diagnose model, the Enhanced Liver Fibrosis Panel, using a cutoff of 10.5, had the best area in the curve overall, so it was the most accurate. But that was due to the fact that transient elastography had some failures due to body habitus. And so when we actually look at it in a per protocol, so who was able to get a successful transient elastography done, transient elastography with a cutoff of 15 kilopascals had the best screening parameters for detecting advanced fibrosis in ALD, with a positive predictive value of 84% and a negative predictive value of 98%. So I also want to show some data that non-invasive testing has similar prognostic performance to liver biopsies in this patient population. So this was a cohort study that was published in 2021 in JHEP, and the authors found that transient elastography and the Enhanced Liver Fibrosis Panel perform similarly to liver biopsy in assessing risk of liver-related events over time. So this study really supports that non-invasive testing is likely adequate to assess fibrosis and prognosticate in our patients without the need for liver biopsy in most cases, obviously not all cases. So we have all these different tests available to us. How should we approach testing for fibrosis in our patients? So this study published in Hepatology examined the cost effectiveness of different approaches of doing non-invasive testing for fibrosis and ALD. And they found that the most cost-effective approach in primary care settings was to actually start with FIB4 and then serologic testing with the Enhanced Liver Fibrosis Panel, then followed by liver stiffness measurements such as transient elastography. In secondary or specialist care, it was actually more cost effective to go straight to transient elastography. So how do we put this all together? This is a really great diagram from a review that was published in Hepatology last year, where the authors recommend first performing serologic testing to assess for risk of fibrosis and ALD, and they have different cutoffs for FIB4, Forn's index, liver risk score. If low risk based on this testing, they often don't need further assessment. However, if there's intermediate risk, you can follow that up with the Enhanced Liver Fibrosis Panel or Fibro test, and then that can be followed by transient elastography as needed. And then if high risk, that's an appropriate time to refer to specialty care where patients can actually go straight to transient elastography. We should also note that liver stiffness can improve pretty quickly after alcohol abstinence. The acute impact of alcohol on hepatic inflammation likely impacts liver stiffness measurements in transient elastography. And so in this prospective cohort study, patients with alcohol use disorder had transient elastography measured at baseline, 4 weeks, and 24 weeks. And among patients who were able to abstain from alcohol during the follow-up period, we saw that at 4 weeks, they had an average of 2.6 kilopascal reduction in their transient elastography measurements. And after 24 weeks, there was an average reduction of 6.1 kilopascals. So this suggests if we, have a patient in our clinic and we do transient elastography up front and it's elevated, to consider repeating it after a period of abstinence and maybe try to encourage our patients that this can improve with abstinence. So in summary, patients with unhealthy alcohol use have high rates of steatosis and fibrosis. And when thinking about screening for and detecting ALD early, we first need to detect unhealthy alcohol use with widespread screening using validated tools like the Single Alcohol Screening Questionnaire or the Audit-C. We should screen for ALD in all patients with unhealthy alcohol use and also patients who have moderate alcohol use and metabolic syndrome or Maslow's risk factors. The initial workup involves some basic labs and workup for other etiologies of liver disease as well as an ultrasound. And then the non-invasive assessment of fibrosis is really important. The Enhanced Liver Fibrosis Panel and vibration-controlled transient elastography perform the best in ALD. And then in primary care settings, really, they can start with FIB4, then ELF, and then followed up by transient elastography and specialist referral. But in specialty care, it's actually cost-effective to proceed directly to vibration-controlled transient elastography. And then finally, liver stiffness can improve with abstinence, and so we should reassess and follow up on our patients to see if their fibrosis does improve. So I just want to say thank you for everyone for coming today, and thank you for DDW and session organizers.
Thank you all for attending our session on practical treatment approaches to alcohol-associated liver disease. On behalf of Suthan and I'd like to thank our outstanding speakers today for providing us with their actionable insights. We're going to have a Q&A, so I'm going to invite all of our speakers to the podium so you can ask any of your questions. Okay, we'll start with our first question.
Thank you. So I'm Hannah Blaney. I'm a transplant hepatology fellow at Georgetown. Is this working? If not, yeah. I can. Okay, good. So this question is for Dr. Im, something that we were actually talking about. So steroid use in treating alcohol-associated hepatitis is very variable. For example, my center, we do not use steroids whatsoever to treat alcohol-associated hepatitis. And the reasons that we don't is the risk of infection pre-transplant, as we're a fairly aggressive center for transplanting alcohol-associated hepatitis, and then the fear of infections post-transplant, primarily fungal infections. I really like Dr. Kulkarni's study with the rapid taper, and I'm hoping that may kind of help shift some of the use for using steroids in select patients. What advice do you have for centers like mine that are not using steroids and how to kind of use them appropriately and kind of convince attendings that maybe don't like to use steroids in some of our patients.
Yeah, thanks, Hannah, for the great question. You're not alone, or your center's not alone. I think Mayo Clinic also doesn't use steroids. If you look at just very bluntly the best data on corticosteroids versus toxyphylline from the STOPA trial, just bluntly, it was not significant. The p-value was 0.06, right? But when you do age matching and other confounding matches, then the p-value is significant, right? So it kind of depends on whether you feel that that kind of sub-analysis is really appropriate or not. The point about fungal infections, most of the data is actually from France, not from the U.S. That there's an increased risk of fungal infections. We know infections in general, usually bacterial, are common in severe ALCAP. I would say that the experience or the mostly negative experience in steroids has to do with decades of experience of patients who are probably inappropriately treated for steroids. The things that we're learning, with ACLF and AKI and infections and cultures. I mean, not all centers even do diagnostic paracentesis in the emergency room either, right? So there's a wide variation in liver-related care. And I think that people have been, quote, burned by corticosteroids in this sort of life-threatening situation. So I think if you can make a compelling case for a kind of narrow window of the ideal patient with certain caveats in place and criteria for those patients who are clearly going to go on the transplant pathway, now that early liver transplant is quite well accepted, then I think that might be a way for you to convince your group to say, well, in certain cases, this patient may be appropriate for corticosteroids.
Thank you.
If it's okay, I would like to follow up Hannah's question to Dr. Im. That paper that you referenced, the American Journal of Gastroenterology, it's been framed that the tapering strategy reduces infection and does not have any change in efficacy in terms of mortality outcomes. The glass half full way of looking at that is, despite reducing infection, it did not improve mortality. So how do we, reconcile that fact? And should we, does this imply that those infections were actually really minor? They're actually very treatable, so it didn't impact the mortality at all?
Yeah, it's a single study, right? Even though it's a well done study, I would note that the rate of infections, who in patients who receive steroids was around 30+%, and that is typical of severe ALCAP studies done in India. There have been a lot of them, and the rate, as you've seen in the UK and in France, are much lower than that, right? So that delta is much more easily achievable in terms of significance. And I would say that there is also data and expert opinion that perhaps steroids only works to improve survival at 28 days because you only give it 28 days, right? Perhaps the inflammatory, the need to reduce the inflammatory response and liver regeneration goes beyond 28 days, and so we should actually be giving more steroids beyond that, right? So it's a clinical uncertainty still. Thanks.
Thank you.
Hi. For the combo of steroid and IV NAC, what is the dosage of the IV NAC that we use?
So that's a great question. I don't know off the top of my head. It's slightly different than the dosing for acetaminophen. I believe it's given over 3 days. I'd have to just refer you to the New England Journal paper on that. But it's similar.
Yeah, right. I think the first 2 days, that taper is similar, but you don't extend it for that 2 extra days, 3 instead of 5.
Thanks, Victor.
Do you, at your institutions, do you use N-acetylcysteine routinely or in certain cases? I feel like I see a lot of practice variation with that.
Yeah, I think it's provider dependent. It's sort of one randomized control trial, and so those of us who are interested in it, give it. I mean, it's a very safe medication. We're very used to using it for acetaminophen overdose, and oftentimes patients they're just sort of hanging out and getting steroids anyway. So sometimes it makes us feel better too. But there's more data, that needs to be produced for that.
Okay, we have time for one more question.
Excellent. For the patients that have a mild case of alcoholic hepatitis and they're getting discharged, at what point would you recommend a acamprosate or naltrexone as a way to just prevent them from getting worse?
Do you want to answer that?
Sure. Yeah, thanks. That's a great question. So there have been more and more initiatives on starting these medications in the hospital while patients are still admitted. At our center, we do. It depends on who's on service. We start them at various times, but we also have an addiction medicine consult service that provides sort of a little bit more comprehensive care for kind of aftercare. But we do often start patients while they're in the hospital if they're willing, or at least kind of offer them the menu of options. I think that some of the clinical trials sort of in general kind of have a certain period of abstinence and things that were in their protocol. I guess for a hospitalized patient that would be the case, and so you can start those medications. But I think in the outpatient setting, you don't necessarily have to adhere to the exact clinical trial protocol. So I think that many of these can be started really at any point, even with naltrexone, to try to help patients reduce drinking. But for your specific question, yes, in the hospital, if there's no contraindication, then it would be appropriate.
I'll just quickly add that there's data for severe ALCHEP that in the first 3 months, really it has to do with, in terms of survival, whether the liver gets better or not, right? But if they survive beyond 3 months, 3 to 6 months, it's actually the recurrence of alcohol use that is the driver for mortality beyond that, right? So oftentimes patients are very scared, they're jaundiced, they've been in the hospital, they're not drinking. But when you see them for follow-up, that's when you got to put your psychiatry addiction hat on and really be aggressive to try to really consolidate that to change for the alcohol use.
And I think I'll just add along those lines, anecdotally, I think when patients have sort of these very significant events, that there's a really high level of motivation to not drink. And of course, motivation isn't everything, but I think a lot of patients are like, I don't need medication, I'm never going to drink again. In the outpatient setting, and I think that I've just kind of seen patients who are started on the inpatient setting and have time to kind of think about the decision and sort of begin the medication are more likely to continue it in the outpatient setting than patients who you sort of start the conversation in the outpatient setting. So just something to think about.
All right. Thank you, everyone, again for joining us. Today's session was really thoughtful, and thank you again to our speakers.